This presentation is on a bilateral anterior ilium. It's different from what people call an anterior tilt, being a bilateral or a tilt of the entire pelvis. That is based on a visual assessment and may be correlated with tight hip flexors. But some people have that posture and it's natural for their genetics, for their body type, and you do all the spring testing on the pelvis, it's not restricted. And so that's simply the way they've made. But for what I call a bilateral anterior ilium, it has to meet the definition in which the person lacks posterior spring on the anterior shelf of the ilium on both sides. Okay? And for that pattern, the sacrum can also be restricted, but for efficiency, what you can do is defer checking out the sacrum until after they've treated this, because sometimes bringing the pelvis back on both sides frees up the sacrum about 50% of the time. And the other, you have to treat the sacrum separately. Okay? So the self-treatment for this is knees are bent and they're going to hug the bent knee, and if you come straight up, it doesn't work. I have a very nice video demonstration of that. But if you go outward about 15-degree angle, such that the inside of your knee would just touch the outside of the shoulder, the deltoid, that's what we're after. That's the angle. And you just bring the leg up until you encounter a barrier. And then you just hold it there. So it's, I don't like the word stretching because it's more effort on the patient's part. I like the term that I'm going to start using: position, near end range, and hold. Okay? And you do that for 2 minutes. And then you do the very same thing on the opposite side, out about 15 degrees. And again, if it could keep going, the inside of the knee would touch the outside of the shoulder. Okay? So just position and hold. And so it's near the barrier, but I'm not really pushing it all the way to that barrier. The nervous system knows what your intention is, and the nervous system will do the heavy lifting. You're just saying, hey, this is kind of where we'd like to open up some movement. Okay? And, the more gentle we are, the more effective we can be for some of these restrictions. Okay? So after that, you would have them lay on their back and you do the spring testing for posterior rotation. You load it to a stop point and then spring it and appreciate the recoil. And if that's normal now, and 98% of the time it will be, then you're ready to go ahead and evaluate the sacrum. Okay? So I'm going to get my anatomical model here. And with that anterior ilium on both sides, it can carry the sacrum into forward bending. Okay? A lot of this is actually happening at the L5-S1 facet joints. And the reason I can say that is because I had a woman that didn't have any inferior glide to the sacrum, okay? And she didn't have any backward bending spring. And she had a fused sacroiliac joint on both sides. And I know the fusion was solid because she didn't have other mobility in the pelvis. She just had, the sacrum, lack of mobility at the facets, such that I couldn't inferior glide it, okay? And so I treated her. And that was an experiment. I didn't know what I was going to get. And after I treated it, I did get some inferior glide spring and some backward bending spring. And for that reason, it's got to be happening at the lumbosacral facets. So I don't call this forward bending of the sacrum. I don't state that that's happening inside the sacroiliac, but a lot of people believe that that is the one probable type of movement at the SI joint. So anyway, we can argue forever and ever and ever, but I like to just get into effective treatments. Okay, so what I do is I put 2 pillows under their stomach, and I encourage them to make sure it's just the stomach but not the bony pelvis. And then I put another pillow under their ankles. So now we have this pillow just under stomach, not under the bony pelvis. And then I drop the face piece down so they can get a lot of flexion. And so now this model is in flexion. We're optimizing flexion in the lumbar spine and in the pelvis. And then what I do is with my little finger, I isolate the tip of the tailbone and I just fall down onto the sacrum. For many people, there's a natural shelf there. And all I'm going to do is push inferiorly with about 10 pounds of force. No more than 15. And I hold it there for 2 minutes. And sometimes that is magical. The person just feels a lot better when that motion is restored. And then you take pillows away, have them lay on their stomach, and then you retest it, and they should have inferior glide. And it's not really necessary to test the backward bending. I know that's covered in the spring tests, but this is the most common bilateral pattern with bilateral anterior ilium and a sacrum that seems forward bent and lacking inferior glide. The magical treatment is restore the inferior glide. Okay, and we'll stop here. Thank you.